Good morning. Welcome to the first nurses webinar of the Global Initiative for Children's Surgery. My name is Marilyn Butler, and I'm going to be introducing our moderator, and also we're going to shortly have a welcome from our chair of the Global Initiative for Children's Surgery. The first person that I'd like to introduce is Comrade Lual Ayudan Alabumni. I call her Bunmi. And she is the lead of the working group, the nurses working group of the Global Initiative for Children's Surgery. And I'll let her give some thoughts about the webinar. And as soon as we get Professor Ame online, then we will have some welcome remarks from him as well. I'd like to also first thank Lifebox for helping us co-sponsor the webinar, and there are several other partners that are integrally involved with the work of the Global Initiative for Children's Surgery. I'd like to acknowledge them as well. So, Bunmi, would you like to give some thoughts?
Yeah, thank you so much. Once again, my name is Comrade Bunmi Lawan from Nigeria. Good afternoon, good morning, good evening, wherever you are watching us from, you are joining us from. Thank you so much for being part of this webinar. It's so strategic, knowing fully well that 2020 has been declared as the year of the nurses and the midwife. So, and this webinar is actually to celebrate nurses and midwives all over the world for what you are doing. So by way of introduction, I just want to say that GICS Nursing Group is actually a consortium of nurses all over the world that promotes children's surgery, timely, quality, and safe surgical care for the children anywhere all over the world. And the objective of this webinar, we hope and believe that at the end of this webinar, which will be able to appreciate similarity and diversity in challenges of pediatric surgical services during this period of pandemic, and also to identify resources for strengthening pediatric surgical nursing care. Of course, we also hope that at the end of the webinar, we'll be able to build a consensus on ways to handle the backlog of elective pediatric surgery. Of course, we know that most of the country now we are facing with that now. We also want to develop strategies to motivate nurses and promote teamwork. In the space of surgical care, particularly pediatric surgical care, we need teamwork. So we need to promote teamwork, and that is what GICS Nursing Group is doing right now. Enumerate how COVID-19 pandemic influences pediatric surgical services in low and middle income countries. So, and GICS Nursing Group, like I said earlier on, is actually a consortium of nurses and midwives with different specialty, institution and organization from around the world, both from LMIC and the high income country, representing from a variety of nursing discipline. As we know that in nursing, we have different specialty, pediatrics, as I'm a pediatric nurse, perioperative nursing, anesthetic nursing, cardiothoracic, neonatal and trauma, and all the specialties that we have. So we come together in order to promote quality and accessible pediatric surgical services all over the world without leaving anyone behind. And the mission is, of course, to define and promote optimal resources for children's surgery in resource-poor region of the world, most especially to accomplish this by engaging leaders like you in multiple disciplines of care and organization whose mission influence children's surgical care. GICS Nursing Group, I also want to say that we galvanize resources, promote commitment, investment to foster collaboration, and advocate for quality, safe, cost-effective, evidence-based, high impact, and of course, very importantly, patient-centered surgical intervention at all levels of service delivery, both tertiary, secondary, or primary healthcare facility, to coordinate research activities and build synergy with partners. Next slide, please. And we also want to use this webinar to encourage you, all the nurses all over the world, be any specialties, provided you have interest of children at heart. So please join us. You can use the chat box, or you can email us directly at geeksurgery@gmail.com. Just send us those variables that you have on our screen, ranging from your name, your organization, your telephone, your email, your specialty. Trust me, we're going to reach back to you. Thank you very much. And I would like to ask if Professor Ame is on ground now. Over to you, Melanie.
Good morning, good afternoon, and good evening, everyone. It's a pleasure to be in the midst of the nursing group. We really cannot achieve much with children's surgical care without all the very wonderful work that the nurses are doing. And it's really a pleasure to see that this webinar is coming up. It's so gratifying to see that the nursing group is taking the initiative and actually showing us the way that we need to go. And GICS really is solidly behind whatever the nursing group is doing. And we are really looking forward to see the outputs from this meeting getting into the public space beyond the GICS organization. And I really wish, on behalf of the entire GICS leadership, I wish you very productive webinar. Unfortunately, I can't stay through the entire webinar. I had to chair another meeting, but a number of some of the members leadership will be coming in and out throughout the webinar. And if I'm done with the meeting I probably will still come back. So I wish you a very wonderful and successful and productive webinar. Thank you very much.
Thank you so much, Professor Ame. And once again, that is the current chairman for GICS, Global Initiative for Children's Surgery. So now, before we start, I just want to say that please kindly use the chat box to introduce yourself. We want to meet you, want to know you. We also want to partner with you. Use the chat box to communicate with us. And if you have any question, please kindly use the Q&A section to share your question, and trust me, the faculty will address the question. Thank you once again, and you are welcome. So now, going to the agenda of the day, trust me, we have very seasoned senior colleagues all over the world that's going to share their experiences with us this afternoon. So sit back, enjoy yourself, contribute, because we promise that this webinar is going to be very interactive. So the first panelist I have this afternoon is actually my own Professor Vanita Paul Ravindian, and she's actually very, very resourceful person, a professor in nursing and an award-winning professor. And yes, she has done a whole lot of work in research. She's very resourceful. And this afternoon, she will be the first to take us on the first round of the webinar, and which is titled, How has the COVID-19 pandemic influenced pediatric surgical services in your hospital, in your country? So sit back and enjoy this webinar. Please feel free to use the chat box. Over to you, Prof.
First of all, Bunmi, did you want to introduce each of the speakers first before we go to the panel discussion?
Okay, that is fine. That is fine. So, okay, thank you very much, distinguished participants, and permit me to just go through the list of the panelists that we have this afternoon for this webinar. And the next person I'm going to introduce to you is actually a very a great opportunity for me, an honor to introduce her. And she is by name Melanie Straub, and she's have more than 3 decades of nursing experience. And of course, she specializes in pediatric ICU and trauma. Currently, she's working at the Lucille Packard Children's Hospital, Stanford in the US. And she have a whole lot to share with us this afternoon. Thank you. The next person, please. Yeah, here I present to you Kennedy Kanchigwa. Is actually the GICS nurse lead in Malawi. Is a pediatric surgical nurse in Central Hospital, Kamuzu, forgive my pronunciation. And I met him recently, he's quite resourceful. I'm sure you will enjoy his presentation when the time comes. Next person, please. Yeah, here is my colleagues here in Nigeria, Uche. And Uche Faith, she's a registered midwife working currently with Rose of Sharon Specialist Hospital and Maternity. She's very resourceful. She's young, but she's vibrant. Trust me, you are going to have a lot of motivation from our presentation this afternoon. Yeah, I present to you with joy full in my heart, Dr. Bim Nadi is actually an associate professor in pediatric surgeon. Is one person I respect so much, who really have given a very big voice to support nurses. He promotes teamwork and is also very resourceful. He have a lot of interest in research and publication. So I'm very delighted to have him today as one of our panelists. Thank you very much, Dr. Bim, for joining us this afternoon. Okay, so we are going into the section proper, and we have 3 sections. So the first round of the session is going to look at challenges in pediatric surgical services in LMICs during COVID-19 nurses experience. Over to you, Professor Venita.
Good evening, everyone. I represent India, and my presentation is based on views from nurses working in different hospitals across India, a few hospitals, not all the hospitals. I just would like to introduce the healthcare because I'll be using terminologies which may not be familiar. I'm not sure how well you can see this. The healthcare system in India has private and public sectors. And the private sectors, we have non-profit and profit organizations. The profit ones, we call it as corporate. The non-profit ones, we call it as mission. Mission may be any religious related or even NGOs, the non-governmental organization, others. In the public sector, we have we call it the government hospitals. We have both urban and rural setups. When we look at children with surgical conditions, most of these children are treated in the urban, private, higher specialty hospitals, or in the private sector, the tertiary care hospitals. The lower level hospitals may take care of some conditions, which are pediatric surgical conditions, but most of the difficult cases are taken care in the higher specialty hospitals. Next slide. So we are going to look at the beginning, this is the first talk, we're going to look at influences and impact. These are some of the ways that COVID-19 has influenced us and has had an impact. I'll just quickly go through all these points. The next slide, please. The influences, as we all know, the drastic influence has been because of lockdown, and I'm mainly concentrating on lockdown effects on surgically ill children. And in in children with surgical illness, as we have already talked about, it's mostly collateral damages, which is related to loss of job for parents because of that financial crisis, transport issues because of lack of transport related to lockdown. And in India, there was one big issue, that was migrant workers who had to migrate from place to place when the lockdown occurred. And there was also closure of some healthcare facilities which are at a lower level. And because of that, the access for care was less. And in all that, I'm sure, although we don't have data, less importance was given to pediatric surgical conditions. The other thing that influenced the care of children was fear, panic, and isolation. Not many times it's fear of infection, but many other times it was panic related to isolation, because if you're found positive, you're taken away from your home and you're admitted in the hospitals. That was very scary for people. So all the focus was on COVID, on all other related or other illnesses were forgotten or was not given importance. And there was also worry about infectivity during travel anywhere, to the hospital or anywhere out. Next slide, please. So there was also influences related to government protocols. Everything changed. Postponement of elective surgeries. Only emergency theaters were open because emergencies only were allowed. There were a lot of travel restrictions between districts, between states, between hospitals. And because of that, parents struggled. In one hospital, one of the nurses gave an example of a child with tracheoesophageal fistula. The baby had to be taken to hospital, which was 300 kilometers away. So that took a lot of time. And there was a lot of impact on healthcare facilities because of these influences related to government and other influences. Many hospitals, the beds were converted to COVID beds because the hospitals became COVID designated hospitals. There was loss of designated beds for non-COVID conditions, especially for children, and loss of theater space to do surgeries. Free care was available in public hospitals, but most of the public hospitals or the government hospitals, the beds were converted to COVID. And so children who needed surgery or even people who needed other care were not admitted. In the private setting, there were many hospitals who are willing to admit non-COVID patients, but the expenses was much higher, because the cost involved all the PPE related expenses that was used by healthcare professionals as well. Next slide. So the access to care was an issue for most of our children and most of our patients. The poor access because of closure of hospital or importance given to COVID patients, but not to non-COVID. In our center, we had babies who had to travel a long distance because in their own state, their condition, a baby with meningomyelocele, was not addressed, or they were not having enough trust in certain hospitals, and they had to travel and come to our center. So actually, parents were moving from hospital to hospital. One parent with pyloric stenosis was in tears because the baby had severe vomiting, but they had to go from hospital to hospital where they were hesitant. The hospital healthcare professionals were hesitant to admit this child and handle this child, and finally they ended up in our unit. Now, children with trauma, whereas they continued Actually, we saw a little more incidence of trauma. In many hospitals, they reported this, and they could not be avoided. They had to be treated. And again, the same issues with centers who were not willing to take or who were hesitant to take care of these babies. The impact was also on resources. Initially, there was inadequate resources in many hospitals to take care of this COVID patients, especially if they had to take care of COVID and non-COVID patients. It was very difficult. And the specialty outpatient clinics were closed in more than 50% of hospitals in India. There were no dedicated pediatric surgeons. Children were under the care of general surgeons. So importance was given to more adult patients rather than pediatric patients. One hospital, they said there is a backlog of surgical conditions, but they were not sure how many children were among them because that priority was not given. Children were then referred to other center, which started the cycle of difficulty again for the parents. So my question when I look at these influences impact, I keep thinking of this incidence of, here I have just given the incidence of congenital anomalies. In India, 6 to 7% of children have congenital anomalies. They are born this many, 1.7 million. But where they are going, how they are getting help, and which hospitals are catering to them, we don't have an idea. And what's happening to many of these children if they don't have enough resources to access care is a big question during this pandemic. So I'd like to stop here and hand over the session to Melanie.
Thank you so much, Professor Vanita. That was very explanatory, especially when you talk about access to care. That is really, really an important issue because we know that children form a very, very huge group in each of our country. And now priority is being shifted. So there's a sudden shift of attention to adults, especially to COVID. Thank you so much. Now we move quickly to the next presenter. Over to you, ma'am.
Good morning. I am so thrilled to be here. Thank you so much. It is an honor to be a part of GICS, and I really appreciate you spending your time with us today. I have a little bit different story, but also very familiar to Professor Ravichandran. And so just to give you a little bit of a geography lesson to start, here is our population of the United States, and there is the world population. We have a birth every 8 seconds. We have a death every 12 seconds. So we can go on to the next slide just to give you a little bit of background. The population in 2019 for the United States, the dark green areas you can see are the most populated states. So we want to talk about how COVID pandemic influenced the pediatric surgical services in the US and also globally. Here's the Johns Hopkins Coronavirus Resource Center, and you can see the US is leading in coronaviruses to date around the world, but the world is also suffering. We have global deaths of 889,627 people. And we want to make sure that we honor those people. The number of cases in the US has grown. It continues to grow. Globally, we've had, in the US confirmed, we'd had 6,282,000 people confirmed and almost 200,000 deaths. You can see the cumulative cases by date comparing different countries on this particular slide. And the US has the most cases. The cumulative deaths, again, the US has the most deaths by country. The impact of the state where I live in California, you can see over on the map on the right-hand side where most of our cases are occurring in the dark kind of purplish red areas of the state. Along with the coronavirus, we also are experiencing significant wildfires in our state of California. Right now, in the western states of the US, we have approximately 200 wildfires happening, over 30 of them happening in the state of California. This picture depicts migrant workers on farms with the flames looming in the background, the smoke, and the intensity of the problem with the wildfires and also the migrant workers still out working. For Stanford Children's Health surgical impact, our OR cases, normally in February, we have about 750 cases per month. We canceled 450 of those cases as being non-emergent. Our April cases, the volume were down to 300, and we are able to just now start to ramp back up. So we did have a loss in surgical cases, and the factors were pre-testing. We had to do pre-testing prior to the day of surgery. Clinical visits have been down. Telehealth has been up, and people are afraid to come to have their child's surgery. Referrals have been down due to children not getting their pediatrician checkups. Thank you.
Wow, thank you very much. That was amazing and smart. How we could see that a lot of challenges that COVID-19 has really brought, especially in children's surgery, accessing surgical services. And I'm sure at the end of the day, we'll come up with a consensus to also share to the world what we think as nurses. Thank you very much. So the next presenter is my friend. I call him Ken from Malawi. He's also going to share his own experiences from Malawi. Thank you. You're welcome, Ken.
Thank you, Bumi, and greetings everyone from Malawi. Such a pleasure to be among you this afternoon in Malawi, I guess morning and night elsewhere. I'm proud to present on behalf of my team in Malawi, and my presentation will focus mainly on the effects of COVID-19 at Kamzu Central Hospital where I work. So I'll begin by showing you a few pictures of Kamzu Central Hospital. That is our pediatric surgical ward. It has a capacity of 80 beds, but it can expand from 80 to something like 100 and 120. And what you see there is our high dependence unit. It's a general high dependence unit. It has a capacity of 6 beds. From time to time, we take our surgical patients into that unit. Next slide, please. Next slide, please. Thank you. So answering the question, what is the influence of COVID-19 in pediatric surgery at KCH? I just want to start by giving you a brief background of COVID-19 in Malawi. So we had our first case reported earlier in March this year. And this was a businessman who had traveled to India and come back to Malawi. This is about the same time when we had a spike of COVID-19 cases in Spain and Italy and Shanghai. So we saw a lot of what was happening in these countries on social media and TV. So what happened was with that one case being reported in Malawi, it sparked a lot of shock among people. But the government moved in very quickly, and they isolated the individual, they put him in self-quarantine, and he recovered with time. What we saw next was a slow progression as people coming in from different countries into Malawi were registered to be positive. But the progression was rather slow than other countries. Because of this slow progression, but also the fact that other countries are registering huge numbers of COVID-19, there was kind of divided reaction among the general public. Notably, with the majority of Malawians, which live to make an ends meet every day, they seem not to be very much concerned, because there was a myth that Malawians are actually immune to COVID-19. By this time, we had seen our neighboring countries getting infections, but there was just few cases in Malawi. But on the other hand, most of the working class were really getting worried about what's happening in the countries around Malawi, such that people started taking measures to prevent COVID-19, their own measures. At the same time, the government also initiated a program to contain COVID-19. Institutions likewise also implemented their own separate programs to contain COVID-19. Just a time later from then, we saw one of our own in the healthy sector actually got infected. I think this was a nurse practicing in the private sector. She had some comorbidities and she eventually died of COVID-19. Next slide, please. You gotta go a little bit up. There's a slide up. Anyways, you can maintain that slide. No, up, sorry. If you go upwards, please. Okay, it's okay, you might have removed, that's fine. So we, answering the question, what's the influence of COVID-19 in terms of pediatric surgery delivery? We can look at this question from different angles. We can look at it from the point of quantity. I think it's safe to say that the quantity of pediatric surgical services being sold and being delivered at KCH has been hugely affected. And this is because, as everyone has mentioned, we have ceased to offer OPT services. We have ceased to offer, we are actually told to stop elective cases. So the numbers have drastically gone down of the services that we are offering to our people. We can actually show, I can show you this by a chart. If you go to the next slide, please. This chart is a general chart of our admission, our pediatric unit. This is just general peds, this is not surgical. But what you do see as you look at this chart are these two curves. The blue one represents the year 2020, and the red one represents the year 2019. And notably, what you see in this chart is in 2020, there was almost twice the admissions in pediatric ward than 2019. That's beginning from about January to something like mid-March when we had our first case registered. And we know that this is in Malawi, this is malaria season. We usually have high numbers. But still, it doesn't quite explain why you had such those huge numbers comparing to the previous year. As you can see, like I said, it was almost double the number of admissions in 2020. And we have sought some guidance from our friends in pediatric unit. And what they have told us is that during this period from January to March, we actually had a lot of kids coming to the hospital, being admitted at our hospital with respiratory conditions. They actually have told us that they actually ran out of amoxicillin, they ran out of augmentin. They had actually to write the government and the other people to help with medicines. And bear in mind, this is beginning from January to March, and our first case was only in March. So would it be safe to say that though we're not testing our people that much, that we had COVID-19 cases in January to March. We cannot for sure ascertain to that, because we've also been told that our data system has just been established just last year. So it's possible we lost some admission data from last year, which could describe why we have a difference in admission rate from last year to this year. Moving on to the next chart, just the other chart, please. Right, the chart on the other side, that's our pediatric surgical ward. The other one is pediatric general ward. The other one is pediatric surgical ward. And what you see in that ward, in pediatric surgical ward, is the same story. In this year, we have had a lot of admissions. And most of these cases were either neuro or orthopedic. And we have asked the neuro and orthopedic guys, and they do not have an explanation why, as to early this year, from about February to March, we had a rise in admissions. But still, what you notice is this year, compared to the other 2 years, we still had quite a huge number of patients registering in our pediatric ward. Actually, if you add up the numbers, you find that the average number of patients registered in the year before, in 2018 and 2019, is about 814. And the difference is quite huge, about 200 something or so of the patients that we have in 2018, 2019, and 2020. The takeaway message here is, in this year, we have had a lot of admissions, both in pediatric ward and the pediatric surgical ward, with an increase about 39%, of which we cannot explain to this day why we had that much increase from February to March in our admissions. Could it be COVID? We don't know. Next slide, please. So apart from just the quantity of the services that we're offering at KCH, we can also talk about the quality of the services that we're offering at KCH. Since COVID was registered in Malawi, we have seen our resources being diverted to meet the demands that COVID has brought with it. For example, we have about 15 anesthetists at our institution. And these anesthetists have had to move from their ordinary place of work and cover the isolation center. And nurses in our wards, for example, our surgical pediatric ward has about 15 nurses, and 2 nurses from the ward have had to be moved to assist in isolation center. This in turn has affected the quality of the services that we're offering to children that come to us seeking surgical services. And also, it's not just the resources that have been diverted. We can also think about the working hours that have been reduced as a response to COVID-19. As the public was talking about working from home, the health worker system was also responding by reducing number of workers per shift. For example, our clinic officers, we're having to work on a week shift. So they would have one clinical officer this week, and he takes a break, and another one comes. So the number of clinical officers also changed. Similarly, the number of nurses has also dropped. We have had cases where a whole ward is being covered by just one nurse. I'll give you an example of a time when we're dealing with a GICS study. We had actually 4 gastroschisis patients come to our neonatal unit. And in that unit, there was just one nurse. And the reason there was one nurse is because the other nurses had been moved to, had been given a break so that they would limit exposure to COVID-19. And if you know, gastroschisis is quite demanding. It requires continuous assessment, continuous monitoring. So it was very tough for us since then.
It's time now.
Oh, wow.
So you can just wrap up. Thank you.
All right. So what does it mean to our patient? What these measures mean to our patient is that though we have reduce the volume of work, the quantity has reduced, but not necessarily the quality of care that we're providing to our patients. They're not getting the best of care that we should give them. But also, next slide, please. If you press that again, sorry. But also it means that we have emphasized on the surgical agency rather than the social agency. We're talking about kids now who are having to go to school with stomas. They cannot come back for stoma reversal just because we're not doing electives. So you think about the social consequences that this kid will have to go through just because we have stopped our electives. I think I'll have to stop there for now.
Thank you so much. I really appreciate that. I'm sure that we'll get back to you. What actually stand for me in your presentation is how increased number of pediatric cases we've had. And again, there's resource diversion, reduced work hours, and lack of resources. Again, which means that we are, to a large extent, compromising the rights of our children. Thank you so much. We'll get back to you. Over to you, Uche. Let's hear from you. Thank you.
Good afternoon, everyone. I'm so happy to speak on the challenges to pediatric surgical services encountered here in Nigeria, of which we categorize it as the three major factors: the institutional factors, the workforce related, and the financial factors. Next slide. Okay, the institutional factors has to do with those factors that are encompassed within the facility. We encountered a lot of challenges. Many of such includes transporting children from the community who need surgical care to the hospital due to the basic restrictions on lockdown. Movement was not easy. The major roads were blocked and it was very difficult for them to get to the hospital. There was suspension of all the elective surgical cases in the hospital. The outpatient clinic was closed for more than 2 weeks, and it was really devastating for those children who presented as elective initially, but their cases turned out emergency. There was lack of personal protective equipment to work with here in the hospital. Many of the nurses started to agitate, even some of the doctors. It led to some refusal for them to operate because they can't do without personal protective equipment. There was low workforce. Majority of the nurses were victims of COVID, and the few that were remaining had to really cover up for others, and that was really a problem. There was delay in health seeking and within the referral chain. Some of the hospitals, when being referred from a smaller cadre to a higher cadre, they don't accept referrals anymore because of fear of COVID. So some of the workforce-related factors. Now, children were discharged too early from the hospital, and there was a reduced rate of follow-up care. In order to avoid the hospital congestion, we had to send some children home, which we feel they are stable. But in the long run, they turned out opposite. Then the trained nurses also, they were lacking, the pediatric surgical nurses. Some were victims of COVID, and the ones that are left out, they were not skilled enough to handle post-surgical procedures in children. Then during the heat of the pandemic, surgeons were unwilling to operate because there was paucity and scarcity of personal protective equipment. Then among the healthcare workers, they lacked motivation, they lost morale. It was really a challenge to us. Next slide. Okay, on the financial factors here, it is mind-blowing that COVID really had a lot of impact here on the financial aspect especially. There was double increase in the cost of surgery. For a surgical procedure to be carried out, it means you are preparing double of what it was before. And that was actually difficult for the poor masses to afford. The cost of medical equipment and supplies was grossly increased because face masks alone, the increase in the price of face masks was by 500%, and it's really heartbreaking. Then the transport, again, because of the social distancing norm, people had to carry one or two, and that means you need to pay for other passengers that should be carried before now. So these things really had a lot of effect on us here in Nigeria. Thank you so much.
Wow, Faith, that was amazing and timely. Thank you so much for sharing your experiences from Nigeria perspective. I also want to say that we could see that indeed COVID-19 is a global problem and is really eating hard on the quality services to our children. Thank you once again. And of course, you can see there's a lot of similarity in some of these challenges. And right now, we're going to move quickly to our second round. Please, our distinguished participants, make use of the chat box to share your experiences. And of course, we want to know you, introduce yourself as well. Thank you. So quickly, we move to the second round, where we talk about the major bottleneck in providing timely, safe, and quality surgical nursing care. So we are going to start from you, Professor Venita. Please take over. Thank you.
I'm going to say the bottlenecks as challenges for surgical nursing care under child related and nursing care related. Excellent. So if we look at the children and family, what were some of the challenges in terms of caring for them or from their perspective? What we noticed was because there were restrictions in travel and access, parents tend to keep children at home for longer than coming to the hospital immediately. And we see not only in our hospital, but in other hospitals also, children, especially with surgical conditions, presented with a severe form of illness. That is, we have had many children coming with appendicitis and usually at an advanced stage with ruptured, perforated peritonitis. We had few children, so their hospital stay has been prolonged because of this. And when such children present, we realize that we have to be very good in identifying complication, which has to be assessed and addressed immediately. Triaging at emergency had to be strengthened because we had to address who's sick with non-COVID condition, especially in case of surgical related condition. And along with that, triaging for COVID, positive and negative. So actually the emergency nurses, pediatric emergency nurses had to navigate both triaging for the sick children and triaging for COVID conditions. And we also realized that need for acute intensive care increased because these children came in sick. So either they had tracheoesophageal fistula, children had lung complication by the time they presented to the hospital, children with meningomyelocele had CNS infections. These were some of the things that were noticed by nurses from different hospitals. And parents also had to wait because there was delay in surgery because of these complications. Immediately, surgery could not be performed. And also there were issues with COVID, positive and negative status. And these might have caused, I'm sure it caused increased mortality, but we don't have statistics. Probably, I'm not sure. I can say as far as I know, as far as I have searched, the statistics related to mortality in pediatric surgical in India is not out yet. Children who are posted for surgery had to undergo screening. If they came on time, they still had to have screening. Routine screening in some hospital. In our hospital, it has become routine to screen all children who are undergoing surgery. But even then, surgeons would think, in case some children did not need surgery immediately, then we did admit children without screening, but most of them were screened. But in some hospitals, they were not screened at all. Only if they were symptomatic, they were screened. And if they had to be screened for COVID, and if that was needed, and then parents needed assistance in navigating the process and path of screening procedure. They had to go to different counters different procedures had to be followed before they could be admitted. And family also, there was a restriction to one person in unit in surgical ward, but it was very hard for the parents to keep away from children because they wanted to be part of the rounds and they wanted to know from the doctors what was happening. So it was a sort of a difficult situation between nurses and parents. And especially moms with young children, they needed one more person all the time because their babies were young. They needed assistance with taking care of these babies. So the restrictions frustrated them. Social distancing norm, and in pediatric surgical ward, most of them were newborn, especially if they got admitted with congenital condition. Social distancing norms and use of masks was difficult for families. They needed constant emphasis, and that was another issue that we all faced. And we also realized that though the children were screened, parents and relatives were not screened. They did not undergo screening. So we don't know, or we didn't know how many were asymptomatic positive. So that was something that we had to always remember in our unit, that the children, yes, they are screened, but not others. There were a lot of issues with payment in our unit. For some, not for all, because the cost became a little more because of the cost of PPE that was also included. Many of the private hospitals had to include this because of the use of PPE, especially if they are COVID positive. So there was delay in discharge. People were waiting for reduction. There's a system of reducing amount of payment in our hospital. We have systems for making it free, so people wait for it. And actually there was one baby who was left. The parents left, leaving the baby in the ICU. Not a surgically ill child, but a COVID positive baby. So this was also happening at this time because they were not able to manage financially. And nurses and nursing care was concerned, as far they were concerned, they had to willing to accommodate changes in the pathway of care. We knew that every child had to be, most of them had to be screened, and always the nurses had to check whether COVID negative status was written. And if it was not written on the chart, then they had to make sure the reasons for it not being written. Either it's not done, whether it's mandatory, not mandatory, those things had to be checked. And they had to know what is the COVID protocol. Everything changed, and it kept changing every day. The protocols changed every day. So we had to be careful every day about implementing the necessary protocols. And also we realized that it is not COVID precautions. It had to be universal precautions that had to be followed in non-COVID areas as well, because others were not screened. There were people coming in and going out in the unit. So we had to emphasize for nurses to use N95 or surgical mask, goggles or visor or cap, an apron, even if it is not complete PPE. Some of these had to be insisted, and there were a lot of resistance in wearing some of these because they kept telling them, we cannot start an IV with a visor on. And in India, where the temperature is so high, we were all sweating. It's not, all the units are not air conditioned. So the sweat will be dipping in. So those were issues. And we also needed to modify working pattern according to change in set. Like change in ORs, it was very far. A nearby OR, we changed the OR. So it took 45 minutes to send a child and bring back the child if we had to send the theater. And we had to accommodate other patients, and we had to help in COVID areas where children were admitted. So these were some of the nurses and nursing care issues. Thank you.
Thank you so much. Thank you, Prof. We'll get back to you. It's so interesting to hear you share your experiences all the way from India. And I also want our distinguished participants to know that this webinar is actually by GICS Nursing Group and of course powered by LifeBox. Thank you so much for joining us this afternoon. Of course, what thing that stand strong for me is the fact that the non-COVID area in our facility should always assume universal precaution. Universal precaution is really, really key. And in all of the care, you see that the bulk of the work is on the nurses. Kudos to nurses, kudos to midwives, kudos to all of you who are supporting and caring for our children. Thank you so much. Quickly, we're moving to the next speaker. Go ahead, please. You have the floor.
Thank you. So we want to continue on with bottlenecks, but I also wanted to take pause and actually look at some of the problems that we have had in the US, but also take pause in honoring the year of 2020 as the nurse and midwife. So you'll see a little commercial break away from this where I will be speaking about honoring the healthcare workers around the world. The problem for us in the US was that COVID exposed many vulnerabilities in our healthcare system across the US and across the world. We had a reduction of risk needs to conserve critical resources. We did not have enough PPE. We had shortages of ventilators, ICU beds, bans on surgical services from March through May, resulting in a backlog of uncompleted procedures. We continued experiencing this diminished capacity. We are continuing. Elective surgeries are distinguished between emergent and non-emergent care. So we say the term, and the public understands elective surgery. I don't need to go to the hospital with my child right now, but honestly, most children, it's not elective. They're not getting plastic surgery on their face to make them look prettier. They need the surgery. So the non-emergent care is necessary for these children in order for them to live a productive life. And so when we say elective surgeries are canceled, for children, this means something different. It means that they weren't emergent, but they were urgent. They needed the surgeries. And then there's ample literature that supports worse patient outcomes and higher costs when treatments are delayed. There was an issue with trust in the healthcare team in the hospital for families to come back in the US for these procedures. We still have families when we call them and ask them to come to the hospital for their child's procedure. They say, no, we're too scared. We don't want to come yet. The testing changed constantly. It seemed like almost daily we had different issues with our testing and our procedures. The team of nurses and doctors that were working within the surgical services, they had constant guideline changes every day. We were looking at what the CDC was saying and World Health Organization, and we were continually seeing the guidelines change. So you can imagine keeping everyone up to speed with those changes was difficult. There was immense financial concerns because we do not have universal health care coverage in the US. So the family member may have lost their job, and if they lost their job, they also lost their health care coverage. And so there was no way unless they were able to pay out of pocket. But if you've lost your job, it'd be difficult to pay out of pocket for some of these procedures. They're waiting for procedures, and if so, they're getting sicker and we're seeing poor outcomes. The extended families cannot be with the patients. And I know you've heard this from other countries as well, but we're limited to one caregiver. And so grandparents, extended parents, families, siblings cannot visit their loved one in the hospital. The referrals are not happening from pediatricians because the patients are not being seen. And then educating the families and the staff is difficult because of all of the change in the guidelines. And we have less resources and staffing because we did have staff that fell ill. For the United States, we have a disproportionate group of minorities, of Blacks and Hispanic, Latino families that actually account for 65% of the confirmed cases. So there is a disparity among our minority groups that have had COVID-19. The unemployment situation, you can see on the graph to the left, it rose significantly from up to 14% and higher. So 1.8 million people out of work in July, and that continues to go up. The impact of uninsured population in the United States, so 2 out of 5 people whose partner lost their job or became jobless themselves because of the pandemic said their health coverage was tied to their job. About 5.4 million Americans lost healthcare coverage from February to May. Texas has the highest uninsured rate with 29% of adults uninsured. As schools decide whether to hold in-person learning during COVID-19, a recent analysis of consumer spending resource found nearly 500,000 teachers do not have insurance, which is just you know, unacceptable. More Americans who have lost their jobs are
Thank you,
signing up.
Melania. We have to come back to you.
Yes, 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 yes. Maybe we can come back to some of this.
Okay, okay.
Thank you.
Thank you very, very much. You know, amazing point there. So, you know, it's just to us in Africa, when we hear that there's a financial concern in the country like US, we're like, wow, what will happen to a country like the low and middle income country? So again, that also shows that COVID is a universal problem, and we must come together to address it. Thank you. Over to you, Ken, please.
Can you just, Bumi, I'll speak for a minute. Thank you very much. I will not go beyond my allocated time.
Okay, go ahead.
All right, so right from the start, I need to say here that the stories that I'm hearing here are quite different from what's happening in Malawi. So far, we have tested about 6,000 people, and of those 6,000 people, only 12% has tested positive. I just got information today that our isolation center has no patient as of now. So it's a whole different story hearing from people from India and US. What's changed for us is the daily operation of the hospital. So as we talk about bottlenecks here, I'll be emphasizing on the daily routine of our hospital. Indeed, there's been some changes in the way we work, especially in terms of resources. And I mentioned this area. The major bottleneck is the resources and the support that the nurses need to do their everyday job. Would you move to the next slide, please? Next slide, please. Thank you. So we can think about the human resource factor, for example. I mentioned earlier that we're operating in a system whereby the number of nurses on ward has been reduced. And what this means is the volume of work for one particular nurse is much higher than before. It is very difficult for one particular nurse for example, a neonatal unit to look after 30, 40 babies. It's just unrealistic. So it's very difficult in this period of time as we're responding to COVID-19 to provide quality, individualized surgical care. It's just not possible. We need to come to a place where we get the balance right between protecting our people, but also at the same time providing quality care. And that's kind of a place where we are. We need to work around. So our nursing approach is more responsive than proactive. You find the nurse on the ward is very much focused on managing the ward because there are needs in the ward that should be managed to run a ward than attending to a particular patient. You move to the next slide, please. we also have limitations in terms of theater space. Like I said earlier, our anesthetists have been moving to isolation center. There have been so many times when cases have been canceled just because we do not have an anesthetist. We also have a problem with space where we're going to place our patient after the operation has taken place. Because this patient needs a lot of monitoring, and we're saying that the ward has one nurse. So we are kind of having to take our nurses from our patients from the main major pediatric surgical unit and place them in the high dependency unit. And that's creating a problem for the high dependency units nurses. They're coming back to the surgical team and complaining that you're giving us more work with surgical patients. Though we have limited the number of patients coming to KC, it doesn't mean that we're not getting so many patients. We still have a lot of patients coming with different conditions. You move to the next slide, please. Next.
Thank you. As you round up, please. You have actually spent 5 minutes.
I was going to speak for 1 minute. All right. I guess this is one of our major challenges, that we in this particular region have not much specialized surgical nursing. So the few specialized ones who have stayed for quite some time and have a good understanding of children's needs are the ones now that are being moved and working in isolation ward. So we remain with the general nurses having to take care of pediatric surgical patients, which I guess it is good, but still creates a problem. I guess of us. Oh, thank you for being fair with me. Thank you for being fair with me.
Okay.
All right.
Thank you, Ken. I have to cut you here, please. We'll get back to you soon.
No problem.
All right. Thank you so much. That is fantastic from Malawi. And I could just appreciate how much work we now have on, for the nurses. However, we are saying all of these in order to recognize what is the way forward. So I want to encourage our distinguished participants to please sit back, and that will be time we're going to discuss the way forward. Trust me, you don't want to miss that part. Over to you, Uche.
Thank you so much, Bumi. I really appreciate that. I'm talking again on the bottlenecks we encountered here in Nigeria that really stand in the gap for providing timely and quality surgical nursing care. One of those problems was low nurse-patient staffing ratio. The nurses were assigned to more than 5 patients at a time, and it was really difficult to give the best care ever to those little children who need surgical care there. Some of the nurses also, they lack mentorship and training. Some were less experienced in the area of pediatrics. And because some of the nurses were victims of COVID, other people that are left out had to really cover up for the people who aren't available. And that led to increased workload for them and increased stress. Majority had to work for a longer time. There was longer duty shifts, and that resulted to an increased risk of error. And there was no medical equipment and supplies to also work with, even at the heat of the pandemic. Next slide. Okay, then this thing now really resulted to a lot of problem in the nursing sector, because many patients, they came back with increase in post-surgical sepsis. It was quite alarming because due to those children were being discharged too early from the hospital, and they were advised not to come to the hospital except on emergency. So when they came back, we noticed there was increase in post-surgical sepsis. The cases that were booked early enough, they presented later as emergency. And a booked surgical case, the parents will have to wait for a very long time for their surgery to be performed. And majority of the children, they couldn't make it to their surgery date. They died. These are many things, the bottlenecks, especially in the nursing aspect. The children, majority, after passing through all the rigorous stress on getting to the hospital, they are dead already. Thank you so much.
Oh, thank you very much, Uche. You are always keeping to time. We really appreciate you. When you talk about nurses being infected by COVID-19, I can understand what you mean by that, because I am a COVID-19 survivor myself, and I know what I went through, having to spend that 2 weeks on admission, being managed as a COVID patient. Kudos to all nurses all over the world. Thank you for all the amazing work you are doing. Now we're moving quickly to our next speaker, who I really cherish a lot, a whole lot. In fact, is an embodiment of beauty. When I mean beauty, beauty is not just the physical, but this is a man that I've learned a lot from, how he supports the team of nurses, being an associate professor who really give nurses the opportunity to fulfill their own potential. Over to you, Dr. Beam. Thank you.
Thank you very much, Bumi. Bumi, how long do I have?
That is a wonderful question. Anyway, we have 5 to 7 minutes for you.
Okay, I'll have to be quick. Okay, this is not specifically directed at COVID, but I think this is actually a more important question, because the world will learn to get over COVID, hopefully sooner rather than later. But I think it's going to take the world much longer to get over the shortage of nurses that we have in low-income countries, and improving the disparity in the quality of care between high-income countries and low-income countries. So this is going to be about the extended nursing role generally, and I apologize, I'm no expert in this. So this is mostly about my experiences in our experiences in trying to build a pediatric surgical team. These are just some pediatric surgical interventions. If you take, for example, cannulation, I believe in the US, this is mostly a nursing job. In the UK, when I trained 20 years ago, it was mostly a medical job. In Malawi, it's a shared job between doctors and nurses. So my point is that these different interventions, it doesn't matter whether you're a doctor or a nurse. Who is doing them depends on geography and time. And therefore, what is most important is that the jobs are done well and done in a timely manner and to the satisfaction of our patients. Next. So the 3 stories I want to tell you was, the first one is back in Blantyre, where I started off in Malawi 9 years ago. We had a quality improvement project, and the detail here is not important. We developed a surgical care pathway. Day 1 on the first page is before surgery, page 2 is during surgery, page 3 is an op note, and page 4 was some observations. Now, what is important here is not what's in here, but how it was developed. It was developed in conjunction with the nurses, the anaesthetists, the doctors, all working together. And we produced many versions of this. And so, for example, it probably doesn't project, but at the bottom of the op note, there's a box that says fit for nursing discharge, because we realized that when the clinicians were busy, or especially at weekends, a lot of our patients were being delayed in discharge and the wards were crowding up. So we provided strict protocols that the patient should be feeding, the observation should be okay, the patient should have urinated, and if the clinician thought was fit for nursing discharge, the nurse could discharge themselves. Next, please. And during the introduction, we managed to show a decrease in mean length of stay. Next. My next story is from when I moved to Lilongwe, which is the capital, which is 4 years ago. At the time, there was no specialist pediatric surgeon here. So we had to build the team ourselves. And the interns and the residents would rotate through very quickly. And also, we had no control of which nurses stayed on which wards. Even the nurses on the wards would rotate. So we developed this role, which we called the Pediatric Surgery Quality Improvement Nurse. And this is the original job description. The detail doesn't matter. But what it concentrates on is to assist the pediatric surgical team, to assist the nursing team, to assist in record keeping and research projects, and to share knowledge and expertise, not just with their other nurses, but with the clinical staff, to also train the interns and the residents and the consultants, but also to share their knowledge with the patients and their families. Next, please. So this was 3 years ago, and Kennedy, who was speaking earlier, has been in that role for 3 years. And this is just some of the jobs that he does. So you can see he's quite a busy guy. And a lot of these jobs are traditional nursing roles. Communication between teams, breastfeeding support, social financial support. Some of them are shared roles, wound management, washouts, weekend, etc. But some of them are roles that were more traditionally done by the surgeon. So weekend cover and the management of gastroschisis, which I'll talk to you about later. We never planned it this way. It's just how it's progressed. Next, please. So after my 3 years, I'm convinced that the role has improved quality. However, quality is difficult, demonstrating increased quality is difficult to show. I'm concerned that the training has been a bit ad hoc and that the role is not grounded well in good theoretical background. And I also have concerns about the lack of career structure, and this is donor funded, so sustainability as well. Next. Kennedy, after 3 years, he tells me sometimes, I love my job. What drives me is that I can see the difference I'm making. I see a baby come, I see them leave. That's what excites me and keeps me going. But it's not all perfect. As you can see from the other quotes, he feels he's more effective in some areas than others. He also notices the lack of direction, and he's pulled by so many people. He's got the nursing team, the surgical team, the pediatric team, the patients, the interns. So it can be an emotionally exhausting job. He says, some days I'm very compassionate. Some days I worry I lose my compassion. Next. So my third story is about the non-operative bedside management of gastroschisis. This is a 7-center, 3-country project that we're involved with in sub-Saharan Africa. We have developed protocols with local teams in the non-operative bedside management of gastroschisis, which involves simulation training. In the middle picture, you can see Watson, who is one of our nursery nurses. So we trained our community central hospital nurses first, and here he's giving simulation training on a dummy of a gastroschisis, and he's giving this training to the people in the other slide who have come from the districts. So now we have a protocol-driven, nurse-led care of gastroschisis, and we have about 4 or 5 nurses on the neonatal unit who are competent at not just advising pre-transfer resuscitation, but also resuscitating the child when they arrive, applying the silo, doing the reductions, and removing the silo themselves. Our results have not been amazing. We need to really know what they are, but probably around 15% survival. However, that is an improvement on what we had before, and we're still learning, and we hope to continue to learn. Next slide. So what have I taken away from this experience? Well, initially I was a bit skeptical because, as we've all heard, the world over, our nurses are overworked, they're underappreciated, and morale is not always good. And I was concerned about giving them more work to do, how this would go down. But on the contrary, what I've realized is that people do respond positively to increased workload, even when they're working very hard. What they say is they know they can make a difference. We have been empowered to do this. However, I must add that it's not easy. In order to do this, we had a surgeon, a nurse, and a gastroenterologist come from another country and provide 1 month of intensive training. So we have to see whether this is sustainable. Next. So a little bit about advanced practice providers. I am no expert on this. I found this paper from the Israel Journal of Health Policy to be a great summary. And what the take-home messages I got was that in many organizations, WHO, OECD, Institute of Medicine, that are looking in to advanced practice providers. Okay? And there's a lot of evidence that these advanced practice providers provide good quality care. And actually there's little evidence that they provide poor quality care, although some physicians do question their use. Broadly speaking, there are 2 routes to this. There's the nursing route, and these have a variety of different names. The paper identified at least 13 titles like consultant nurse, nurse specialist, etc. And then there's the non-nursing route. In the US and more recently in the UK, called physician's assistants. In Malawi, they're called clinical officers. In Zambia, they're called licentiates. In South Africa, they're called clinical associates. What is clear is that the number of these people are increasing, and there is a policy push to increase this even more. Next. So these are the factors that have been identified in high-income countries, but the circled ones, most of them are as important, if not more acute, in low-income countries. Next. I'll miss this slide for time. Next.
Yeah.
In conclusion, in high-income countries, nurse practitioners are doing well, but we always must consider context. Next. And this is the context. You can see that in low-income countries, we have an order of magnitude less nurses. Okay? And this is exactly what you see on the ward. This graph shows you that Malawi has 40 times less nurses per population than the UK. And this is exactly what you see when you go to our surgical ward. Sometimes there is one nurse looking after 60, there's a nursing ratio of 1 to 60 or 80. Whereas in the UK, it's usually no more than 1 to 5. On our neonatal unit, in the high dependency area, there's a nursing ratio of sometimes 1 to 40. In the UK, it would be no more than 1 to 2. Next. So, what are our barriers to developing advanced practice in low-income countries? Well, lack of inadequate number of nurses, lack of recognition from governing bodies and political will, lack of faculty to teach is a problem in high-income countries as well, and lack of career and financial incentives. Next. So how do we go forward? Well, at the moment, it's mostly ad hoc. We need to make sure that quality does not suffer. It's very important that these initiatives are led by nurses. Otherwise, they will not work. We need inputs from our partners in high-income countries who have experience of this, but this must be context-specific and must be led from the low-income partners. And what is going to be difficult is how to develop a body of literature to show that we can do this safely when we're so busy working. Next. So I think our first step should be a GICS pediatric surgical nursing resource on the web. So people know where to go to learn more about such complex and varied conditions. And I know Bumi is interested to turn this into a formal curriculum and maybe later on into a course or a degree. Next. So this is a picture of one of our nurse-led gastroschisis babies about to go home. I'd like to thank you all and welcome your thoughts and questions.
Thank you so much for amazing presentation. It's as if you should go on and on and on. You know, you can imagine that for nurses in Malawi to lead surgical team, to do some specific thing, to apply silo, to remove that. For now in Nigeria, we don't have that. And I really want our Nigerian counterparts to really learn from Malawi. Once again, thank you very much. Now we quickly move on to panel discussion, so go back again to the nurses. We want to know what is the way forward. We've identified numerous challenges, numerous bottlenecks, but as nurses, we represent the largest number of healthcare professionals. What are the available opportunity resources that we can harness to promote quality surgical nursing care and improve investment at the district level, national level, at the global level? So next. Thank you. The next person is our Professor. Can we have your take on this topic? Thank you.
So I just would like to highlight how do we promote quality, especially during this time of COVID, and what do we do to move forward? These are the things that I have. We know that the goal is to provide timely surgical care, presenting with urgent and emergent surgical condition while optimizing resources, especially during COVID. How do we do that? What are some of the things? Some points that I have highlighted include training of nurses in surgical nursing care that will continue in hospitals that have, especially review on pediatric surgical care and complications at this time, introduction to new nurses who are posted in wards. What we see is because of the COVID duty, the surgical nurses are posted in COVID areas, either with the children or with adults. So we have a rotation. So sometimes nurses who are not familiar are coming here. So it's important that they are introduced to surgical nursing, especially pediatric surgical nursing. And if we go to an area where there are children, then we need to teach them. And training on infection control, use of PPE, that is ongoing in our hospital. Always, every day, certain number of nurses are trained on this use of PPE and infection control. And we also have to think of safety of nurses as they give care in the non-COVID and COVID areas. Next slide. And we also have to think of parents and children in this time, especially when they are admitted with COVID. How do we make sure that they follow all infection control protocol, but at the same time engage them so that they don't fear the nurses who are in PPE and they enjoy. Actually, it's a better experience than a scary experience. So that's another thing that we think and modify. And pediatric nurses are very much appreciated for the way they deal with children in COVID wards or when they need isolation. Next slide. Yeah. Then the most important thing is that we establish clear protocols and make sure that we make decisions appropriately, especially those who are in leadership position, and update protocols and policies as needed. And also when we come up with certain situations. There was a child here who came to us for elective surgery, but the policy is no elective surgery. What do we do? But this child has traveled so many kilometers across states, and they have believed in the unit and come. We cannot make them wait for a long time because of financial issues. There was a lot of discussion on this, and there was a need for going ahead with the elective surgery for this child because of various reasons. So these types of decisions may have to be made when necessary, and clear communications on all expectations. What do the surgeons expect? What do the theater or nurses expect? What do we do? What does the administration expect? These were things that we had to keep on finding out and translating it to all the nurses. And we also had a COVID command center, which really was helpful for us. Next one, next slide. We also had periodic evaluation going on. It's still going on. Daily audits on how nurses and healthcare professionals use PPE, how do they follow infection control, and how is care provided during this time, and what is their knowledge and skill. These are evaluations that are ongoing related to this. So these are some of the quality things that we have to remember. But what do we do as pediatric surgical nurses? What is the way forward? The immediate action would be to encourage hospitals we do not have policies, may establish protocols. Maybe we can share resources, web pages, and standards. So all of us can follow this. All the units can follow. And we also can, we in India, we would like to work along with the GICS team, especially Dr. Risha, in continuing the training of trainers in India. We have started this training, initiated to train more pediatric surgical nurses in pediatric surgical nursing care. Training to include, it should include component of managing pandemics probably next time. We also have to introduce the importance of pediatric surgical nursing care through education and training, increase membership in GICS so we can extend. I was thinking each one catch one, at least one nurse, catch another nurse, make them members. So we are going bigger, growing bigger, and involve new members. I'm sure there are many members who can contribute to pediatric surgical nursing care. So involve them in promoting ped surgical nursing nationally and regionally and internationally. And my aim and dream is to develop nursing competencies for pediatric surgical nursing, especially for LMICs, which are context-based, but we can get the help from our friends from developed countries. So I'd like to conclude. No, you have to accept you cannot avoid the situation of COVID. We have to adapt by inculcating or introducing or getting used to new protocols, but keep advancing in COVID, with COVID, and out of COVID. So at this time, I'm grateful for all those who provided information. Thank you.
Thank you so much, Prof. Thank you. Amazing presentation. And I really want to encourage our participants to please join GICS Nursing Group. It's is one amazing group I've ever come across in my life. You're welcome on board. Over to you, Melanie. Thank you so
Okay,
much.
thank you very much. Yes, so what are our available opportunities and resources? Next slide, please. For Stanford Children's Health, we did ramp down quickly, and we feel like safely following the CDC recommendations, although those were continually changing. We ramped up as soon as the CDC guidelines approved. We had some planning for pre-testing sites, pre-anesthesia phone calls, ensuring families that the hospital was safe. We had social distancing in our lobbies and our treatment rooms, and we did have enough pre-test the day the patient wasn't tested at off-site areas. So we had changes in our PPE guidelines and workflows, but we tried to keep up with them the best that we could. We felt like we kept our employees safe, having enough PPE. And communication we found was key to work with all of our key stakeholders, to include surgery, anesthesia, OR schedulers. I wanted to celebrate some of the world successes here with some of these photos. I came across them preparing for this talk from Getty's Images and United Press, and I just thought the world is being very creative, and you can take the time when you see these slides to go through these. It's just amazing. I mean, there's endogenous people with masks on, so some healthcare worker actually provided them with masks and gave them education. We have people honoring the dead, which we need to take the time. We need to continue testing for children. We need to make it less scary for the kids and be playful. And here are some of those images, and you will have these slides. And we want to protect all the children from universal masking and keep the infants safe, children going back to school, keep the healthcare workers safe, give them time to rest, and then keep the staff safe, and thank them for their dedication. Allow them time to be recreational, make sure our food supply chain is safe and that it's ample, and that we have spaces provided for those in need. And just remember that your patients are someone's loved one. And again, you will have access to all of these slides and can read through them, but they're images from all over the world. And we just need to stay strong and remember your sense of humor. We have, if you'll go back to one slide, we have additional resources that I've placed on here in the US that will hopefully be helpful to some of the nurses around the world, and we can promote that these organizations give out free educational resources. I think we need to go to each of these organizations and make sure that they are giving access to their educational resources to the world's nurses. So I think this will be a very important step in GICS moving forward, and I'm really looking forward to participating in that. Next slide. There has been some literature. We did some literature that there is backlog in 38 children's hospitals in the US. And so that you have additional reading related to that you can look at. Some of the solutions, now that the states have lifted the bans, some of the hospitals are ramping up their strategies, but we want to be careful of bottlenecks impeding overall hospital operations. We must not inadvertently favor patients with socioeconomic privileges. I think that is extremely important. We want to be mindful of clinical, ethical, and financial goals of the hospitals and reinforce this with our hospital settings. There were 5 strategies for healthcare leaders. I'm not going to go through all of them. You will have these materials so we can you'll have access to all of that. There were some CMS guidelines. This is kind of our government guidelines that came out of how to ramp back surgery in a tiered fashion, and so you'll have access to this as well. And this is the 38 hospitals that got together for the surgical response, and you'll have access to that article as well. And this is just the results of that study. And so all of the hospitals in the study did have internal structural changes related to COVID-19. They had clinical flow changes as well, and you can read this on your own time. It'll be available. And operative scheduling and workflow processes had changed. And most of them did implement telehealth, which was something that was big for the US because we weren't using it collectively, but we are using it more now. The policies around COVID-19 and the safety and prevention were used in most of these 38 hospitals that participated in the study. And there was impact on the training of the nurses and the residents and the fellows. So imagine being a nursing student trying to learn at the final stages of starting your nursing career and having to be told that you can't be a part of that training process because you're not allowed in the patient's room. And so there were lots of nursing students that are now deemed as nurses that did not get the quality of nursing education that they typically would have, and physicians as well. These are just some more resources I threw into the PowerPoint for you. The American College of Surgeons has lots of resources preparing families of how to have surgery. They have a ton of valuable information. So you have it all. The changes have been rapid and dynamic in nature. The full impact we still do not know. And we're optimistic that a dedicated community of professionals such as GICS can come together to address these challenges and restore high quality surgical care to those in need. That's it. Thank you very much.
Thank you so much. I'm actually happy with the resources that you've made available. And I want to assure all our participants that they will really have this material. Over to you, Kennedy, please.
All right, thank you again, Bumi. So, in low and middle income resource countries, indeed, we are faced with lots of challenges in providing pediatric surgical nursing care. And like you rightly said, nurses form a large number of the workforce, even here in low-income countries. But it's also worth to say that nurses mostly are very much involved in policy implementation than policy formulation. Yet the same nurses have a unique angle on which they see the reality on the ground. So I think as nurses who are practicing on the ground, we do have those opportunities and resources. But what we lack in low-income countries is the knowledge of what to do and where to get those resources. We can try, sorry, I just have one slide, thank you. We can try working with only what we already have on the ground. And we can sort things beginning at a world level, at an institutional level, a national level, and international level. What we need in low-income countries is to define the role of a nurse. Because usually in my country, there's this language that goes around that says ideal nursing. And what we mean by ideal nursing is what we've read from the books from high-income countries, which when you break down to what's happening on the ground does not really apply because the setting is totally different. I think in low-income countries, we need to define what nursing means. I'll give you an example. At my institution, nurses spend a lot of time dealing with paperwork. So their time is diverted to admitting patients and writing patient orders. They spend a lot of time dealing with paper than the actual patient, thereby depriving the patient direct nursing care. What if we in low-resource countries would think of a strategy whereby we have, for example, ward clerks who are collecting data at the ward level so that we free up nurses to engage in actual direct patient to nurse to patient activities. We also need to think about empowering our patients to take part in their own care. In Africa, or rather in low-income countries, one thing we could do is to give them to give our patients enough support so that, for example, they could take care of their own medication, oral medications. I know it's done elsewhere, and it could be a debatable issue, but I think it's a worthy thing to free up the nurse to be able to do things which the patient cannot do. In that way, we're able to improve the quality of care. Because what is happening is we're spending a lot of time in resources dealing with stuff which the patient would do. I think one of the nursing theorists, is it Dorothea Orin, mentions about involving the patient in patient care, and we don't see that here in low-income countries. That's sort of a lot of the nurses diverted to jobs which would be carried out by someone else. So my appeal is, could we try to redefine nursing according to our need on the ground, rather than what we're seeing in textbooks from high-income countries? Yes, it's not telling. But also, apart from that, the other strategy we could use, the other resource we have, is what Biff said here. If we could think about specializing nurses, because what happens is we have in our unit, for example, wards that are demarcated into general pediatric ward, neuro ward, and that's neurosurgery, orthopedic, and urology. And you have a general nurse who is taking care of all these patients and does not have the in-depth knowledge of how to take care of a urology patient, because you just don't go as that too much depth in general nursing about urology. So I'm arguing, can we try to specialize nurses in, say, pediatric surgical nursing in urology, so that we're able to meet the needs of urology? We're able to meet the needs of neurosurgery. I think we're missing out a lot by just generalizing nurses to be general nurses to do everything. And we're lacking depth of caring for our patients. But also, one thing I have learned as I've been interacting with the GICS nurses is the fact that advocacy makes a huge change on the ground. I think in my country, and it could be true elsewhere, we're falling short in advancing nursing advocacy. What I mean is by empowering nurses to advocate for resources for surgical nursing care. I'll give you an example. In our pediatric unit, we also admit ENT patients. And we have noted for a long time that we have a lot of patients, a lot of babies coming for admission after swallowing a coin. And when you think about that coin, it's a coin that you cannot use to buy anything. We actually did the math. The coin could be something like 0.6 cents worth. It's a coin that you won't use anywhere. These coins are still being manufactured, and our kids are still swallowing them. So what he's saying is, what if we encourage nurses to be advocates of policies whereby, for example, we could show the government the data we have about, for example, how many kids have been swallowing coins in a year.
Thank you.
You're welcome.
You know, it's so difficult to say stop, because we just want it to go on and on and on, but time will not permit us. I really want to appreciate your point on partnership, and of course, advocacy is key, because whatever advancements we are looking at or we are craving for as nurses, advocacy plays a huge role. Over to you, Uche. Thank you, Ken.
Thank you very much, Bumi. We keep talking about motivation and support. Yes, nurses need motivation. They need support in order to put in their best in everything they do. If nurses are being able to take up lead roles in the area of pediatric surgical services. I think that will go a long way. So one of the strategies should be organization of leadership and mentorship program for nurses. When nurses have been involved in decision making, that will go a long way to help pediatric surgical nursing intervention. Also, collaboration with health professionals. It will help to improve the patient's outcome, reduce the length of hospital stay, and save costs. And moreover, improve job satisfaction among the nurses. Because our aim should be to see your patient smile. And at the end of the day, there is this joy that comes with it. And we can make use of our available resources at the district level, national level, and global level as well. We already have our primary health care at the district level. They are the first line of care, and moreover, they should be well equipped. Pediatric surgical nurses who are well trained should be employed there because they can be able to handle problems at the grassroots. They can be able to identify, assess children who need surgical intervention timely. At the national level, the hospital should know their limit to care and encourage timely referral so that things doesn't get out of hand before the children get to the hospital. At the global level now, there should be collaboration among donor agencies and partnership as well. Conduct of the training program for nurses that are interested in pediatric surgery. That will help us to put up with global best practices and achieve the optimal level of care for our children. Then the way forward. Pandemic is true that the heat is gradually subsiding in all countries, but we don't have to keep on sobering on what has happened. We need to move forward. Electronic communication will help us better. When the healthcare workers, when they are assured, when their health is also insured, that will go a long way. They will have something to fall back on, so that in case of pandemic, they don't have to go back. They don't have to relent in doing what they need to do. They should be encouraged. Incentives be given to health workers because they are always at the front line of a pandemic. They have loved ones as well. They have people out there. So I think they should be encouraged, and teamwork should be the way out. We cannot do it alone. We need the doctors, we need other healthcare workers, and together we make a global impact. Thank you so much.
Thank you so much. Yeah, together we make a global impact. That is amazing from Faith. Thank you so much. And quickly, I want to say that the lead role by nurses is very important, not to keep waiting and waiting to the patient deteriorate. Thank you so much for that piece. So moving forward now, we're going to go quickly to Dr. Bim again to have his presentation. Over to you, please.
Next slide, please. So I'll keep this short. We will have to decide for ourselves what our own personal unit backlogs will be. Next slide. When we think about the pediatric surgical team, it's not just nurses, anesthetists, and surgeons. We have to think about the wider team. It doesn't matter getting more of us in. If you haven't got enough sets, you won't be able to do the backlog of surgery. It's a big job. Next slide. I think doing nothing is not really an option. You know, there is going to be a huge backlog. We already have the access and quality here is already not great. It's just going to go get worse. You know, we'll have increased morbidity and mortality. So we need to start planning now about what we can do. And this is not from the literature, just my thoughts. So either we extend nurse working hours, we have surgical camps, or we have health system strengthening. Next slide. So you can either work on weekends, we can work at nighttime, or we can extend operating hours. The advantage of this is it's possible with existing staff who have local knowledge, but they're already working very hard. We need to make sure they don't burn out. We need to get the remuneration right. We need to pay them enough so that they do come in to do the extra work, but we must make sure we don't pay them so much that it creates perverse incentives. Next slide. Surgical camps have the advantage of being able to do a high volume in a very low time. However, we must be careful that we don't divert local resources away from our normal activities. Surgical camps are a double-edged sword. They can, depends on how they're done. They can be done very well, they can be done very badly. Sometimes we have well-known international surgical camps come to our hospital and all our elective cases are stopped. That is not acceptable. I think, if you are going to do it, the way forward is to have, joint expat and local teams sharing knowledge together and developing long-term partnerships, being aware of how the camps affect local services. Next slide. Health system strengthening. Well, this is the the holy grail, isn't it? It improves the whole system, doesn't just deal with the backlog, it can be more sustainable, and it doesn't burn out our already overworked nurses and clinicians. Obviously, the problems is it's expensive, it's complicated, and it takes a long time to train a nurse or a doctor. But I've written here it usually takes a long time because in Malawi, we have possibly hundreds of nurses sitting at home without a job. That is a tragedy. So health system strengthening with the correct funding can happen quickly. Next slide. This is a quote from Margaret Chan, previous director of the World Health Organization. I'll let you read it in your own time. I mean, many of us hope that the pandemic is a time of crisis, and the time of crisis is also a time of opportunity. And many of us hope that we will try and take away as many positives from this as possible. We dream of better work-life balance. We dream of a life where there's less consumerism, a dream of a world which is more sensitive to global warming and ecology. And we dream of a world that is where there's less health inequality. However, while we're dreaming and hoping for the best, we must prepare for the worst. And therefore, we must consider other strategies such as extended working and surgical camps. Thank you.
Okay, I just want to say thank you to everybody. That's been an amazing time, honestly. But one thing that is for sure is the need for nurses to be advanced in all ramifications, and training and advanced nursing is key. And that is why GICS Nursing Group is really beckoning on you. Please join the train, join us, to this fight. We cannot do it alone. We ask the partners to please reach out to us. We want to do more, and we cannot do it without your support. Again, thank you to GICS. Thank you to Lifebox for supporting us. We can't do this without you. Thanks a lot. Please, once again, if you are interested in joining GICS Nursing Group, reach out to us, send us your email, and your contacts will definitely reach out to you. We really want a representative from all over the world. Together we are bigger and we'll make better impact. Thank you.
Thank you all.
Sorry?
Thank you, I said.
Okay.
Once again, thank you from the GICS leadership as well. I've a special thanks to Lifebox for helping us host the webinar, and I hope you can see the email address that's listed here. You can send any of your questions to that email address, and I'll forward them to Bunmi. Also, if you're interested in joining the nurses working group, then use that email address as well, and I'll get the information to Bunmi. We're very eager to have as many people involved as possible.